Good morning, all. I'm presenting on tips and tricks on gonioscopy. Gonioscopy forms part of a complete ophthalmic examination which every ophthalmologist must be able to perform. Why do we need gonioscopy? It is due to the optical principle of critical angle. The light rays coming from the anterior chamber angle strikes the cornea at an angle which exceeds this critical angle. Thus, it gets reflected back into the anterior chamber, preventing direct visualization of the angle. So we use a contact lens which bridges the between the anterior film and the uh, cornea. Anterior curvature of the contact lens in direct gonioscopy is such that the angle of incidence is less than this critical angle and the light rays are reflected at the new contact lens air interface and we get an erect image of the angle structures, and in indirect gonioscopy we get a mirror image of the angle structures. Who needs gonioscopy? Ideally, all patients. It must be performed at least in all glaucoma suspects where suspicion is based on family history of glaucoma, intraocular pressure, Van Herrick's test, optic disc appearance. Also, in patients with history of ocular trauma, uveitis, patients suspecting secondary glaucoma, it is also used to assess the angle after laser peripheral iridotomy. And also, if there is any unexplained change either in the intraocular pressure spike or field progression, which all lenses should be used. These are the indirect gonioprisms, Goldman single mirror and 3 mirror lenses, which uses a coupling agent to fill the space between the cornea and the lens because of their 7.38 mm posterior radius of curvature. These are the other indirect gonioprisms, C's 4 mirror, Sussman and Posner, which doesn't need a coupling fluid. The other trabeculoplasty lenses are Rich and Latina. Direct gonio lenses are Cope, Barkan, Schwann-Jacob and hands-free gonio lenses. Coming to the technique, do an external eye examination first, then do tonometry before gonioscopy. Explain the procedure to the patient, use a topical anesthesia, make the patient seated comfortably with chin resting and forehead touching the headband and both eyes open. The examiner's elbow should be supported to avoid undue pressure over the globe. Place the lens directly over the cornea. In nervous patients, ask the patient to look up, insert the lens quickly without much loss of coupling fluid, and then ask the patient to look straight. This is how the patient should be seated, how the lens is held in position. In direct gonioscopy, hold the lens with thumb and index finger and brace the other fingers against the patient's face or slit lamp's headband. This allows to rotate the lens continuously without using the second hand and letting go of the slit lamp controls. Keep bubbles out of the methyl cellulose as it will obscure your view. It should be done in a fairly dark room. Pupillary constriction makes a narrow angle appear more open. Use higher magnification of 10 to 25x. Use a fairly short and narrow beam of 2 to 3 mm. If the lens sticks to the eye after examination, ask the patient to tightly close the eye and try detaching the inferior margin of the lens first. Then what to look for? First, identify the angle structures, assess the angle occludability, and then look for other findings in the angle. Identifying the structures from anterior to posterior is mostly preferred. First, identify the Schwalbe's line, which appear as a fine ridge. It is identified by small buildup of pigments. Anterior trabecular meshwork is the second one, which is a white band posterior to the Schwalbe's line. Then comes the posterior pigmented trabecular meshwork, which is a pigmented band posterior to the anterior trabecular meshwork. Then scleral spur appear as a prominent white line posterior to the posterior trabecular meshwork. Ciliary body appears as a grey to dark brown or slate colored band posterior to the scleral spur. Many times, Schwalbe's line may be mistaken for posterior trabecular meshwork due to the pigment dispersion along this line, and this is called Sambolos's line. But in this, the pigmentation will have a salt and pepper appearance, dark and granular, and it will be discontinuous. And pigmented trabecular meshwork, the pigmentation will be brown, fine, and continuous. We can identify the Schwalbe's line with the method of corneal wedge. When a thin slit of light hits the iridocorneal angle at an angle of 10 to 15 degree, two light reflections are seen from the external and the internal corneal surfaces, which pipe down at the corneoscleral junction. This points towards the Schwalbe's line. When the iris has a convex configuration, it is difficult to see the angle structures. Then ask the patient to look in the direction of the mirror or move the mirror towards the angle being viewed. This gives a better view of the angle structures. Now, Assess the occludability. An angle is considered to be occludable if the pigmented trabecular meshwork is not visualized in more than 180 degree of the angle without indentation under appropriate testing conditions. Indentation gonioscopy. When iris covers the trabecular meshwork, it's easy to mistake the non-pigmented trabecular meshwork for scleral spur, pigmented Schwalbe's line for trabecular meshwork, appositional from synechial. In this, indentation gonioscopy is particularly useful. Indentation gonioscopy is used to apply pressure axially towards the center of the eye while the patient is looking straight. Appositional closure opens upon indentation. It also helps to identify the plateau iris configuration, which is due to anteriorly inserted ciliary process. This gives a sine wave and double hump sign on indentation. Then increase the illumination, see for other structures in the angle like abnormal vessel, silicone oil, peripheral anterior synechial, plateau iris configuration and pigmentation, pseudo exfoliation, and in trauma, iridodialysis, angle recession, cyclodialysis cleft. Iris processes are fine, they extend into the scleral spur. Underlying structures can be seen in between, and these will be broken in angle recession. Peripheral anterior synechial will be broad, it extends beyond scleral spur and obscures the view. The normal iris vessels have a radial orientation, and angle vessels are fine, arborizing and crosses scleral spur. Angle recession. In this, the ciliary body band will be wide. They will have a deep anterior chamber and also compare with the other eye. Iridodialysis is the separation of the root of iris from the ciliary body. Cyclodialysis cleft, you can identify the white color of the sclera which is visible. Then direct gonioscopy is performed by a binocular microscope and illuminator. It is done in supine position. Lens is positioned with coupling fluid. We get an erect view. Examiner can scan 360 degree by shifting his chair. It is contraindicated in painful inflamed eye, compromised cornea, suspected open globe injury, or early in course of suspected closed globe injury with hyphema, as the pressure may precipitate rebleed. Then sterilize the lens. So wash with soap and water, soak in 1% sodium hypochlorite for 5 to 10 minutes, rinse and air dry. The secret for a good gonioscopic view is practice, practice and practice. Thank you.
Thank you, Dr. Maya. That was a very good presentation on the basic technique, gonioscopy.